The following podcast is part of a certified educational activity titled Improving the Patient Experience in Geographic Atrophy. Are you putting the latest advances into practice? Access the entire activity and complete the post test at peerview.com/GEH860. Downloadable slides and practice aids are also available. Find out how much you know about optimal management of geographic atrophy through a simple 3-step process in this self-assessment activity comprising 5 question modules. First, answer the baseline question to evaluate your knowledge and skills. Next, review the supporting evidence shared by Eleonora Ladd, MD, PhD. Finally, answer the question again to demonstrate what you've learned. Each correct answer automatically counts toward post-test completion, which means that getting your CME credit is fast and easy.
Hello, I'm Nora Ladd, Vice Chair of Clinical Research and Professor of Ophthalmology at Duke University Medical Center in Durham, North Carolina. Thank you for joining this educational activity on improving the patient experience in geographic atrophy. Our goals for today are listed here. First, to prepare you to advocate for patients impacted by the burdens of geographic atrophy. Next, to equip you with strategies for detecting and monitoring GA. And lastly, but very importantly, provide guidance on integrating treatments for GA into practice. In this module, we'll focus on gaining insights into life with geographic atrophy. Geographic atrophy is defined as one of the advanced forms of age-related macular degeneration. It is characterized by progressive loss of photoreceptors, retinal pigment epithelium, and choriocapillaris. Initially, the disease starts in the perifoveal macula and expands over time to include the foveal area responsible for central vision. Typically, this is a bilateral condition that results in progressive irreversible vision loss. It is very important. It affects more than 5 million individuals globally, and it's increasing as the aging population is over time. It develops in up to 20% of patients with age-related macular degeneration, and unfortunately can progress to central vision loss in as little as 2.5 years. The median annual progression is about 1.78 millimeters square, which doesn't seem like a big area, but in fact, it is very important for visual acuity. This is a diagram that is complex, but showcases the evolution of geographic atrophy over time. The disease starts with normal aging changes, with occasional small drusen and normal pigmentation. But patients at risk have a conglomerate of features, such as drusen accumulation, reticulocytodrusen, hypo and hyperpigmentation of the retinal pigment epithelium, lipofuscin accumulation, immune cell activation, diffuse thickening of Bruch's membrane under the retina, atrophy of the choriocapillaris, and early loss of photoreceptors. Later on in advanced disease, in the atrophic stage, there's RPE cell death as well as photoreceptor cell death, focal thickening of Bruch's membrane, choriocapillaris atrophy, and there are inflammatory cells in the choriocapillaris that are being brought in. These are adjacent to Bruch's membrane. This shows up as a signal of autofluorescence at the lesion edge that we can follow clinically. There are reactive Mueller cells and astrocytes also present in the retina. The impact of geographic atrophy progression on vision loss is dramatic. This is a study of a retrospective cohort in the UK that showed that 2/3 of the patients became ineligible to drive within a median time frame of 1.6 years. 16% of individuals progressed to legal blindness over 6.2 years. And you can see in this diagram the progression of this disease to involve the foveal area over time. Initially starts off with some loss of peripheral low light vision, and patient only notices these under certain conditions or via design test. But later on, there's loss of peripheral vision and low light vision, and the patient starts to compensate increasingly. Later on, there's loss of peripheral and low light vision that's more dramatic, and there are patches of central vision that are being lost. Later on, however, there's loss of central vision, and the patient calls himself blind. Given this dramatic progression to visual function loss, we wanted to evaluate the risk factors and progression of this disease in more detail. Shared risk factors are listed here. They are genetic, such as the ARMS2 genotype, cigarette smoking, um, lack of a Mediterranean diet or healthy diet, and phenotypic characteristics that include reticulosurodrusen and hyperreflective foci. And you can see here that these mainly put you at risk with the exception of Mediterranean diet that is protective and slows down GA expansion. Not shared risk factors are age, CFH genotype, and other genetic variants, and Mediterranean diet components that are listed here. Higher fish intake, higher whole grain intake, whole food intake, lower red meat intake, moderate alcohol, and higher ratio of good fats to bad fats, and these are protective. In the opposite direction of protection, there are the C3 genotype and the ApoE genotype that lead to slower progression of geographic atrophy. The impact of geographic atrophy on vision and overall quality of life is shown on this slide. 100% of patients with GA report difficulty reading. 75% have difficulty driving. 63% have difficulty with chores. More than 40% of eyes with GA are legally blind, and about 25% of patients develop depression. So, mental health is also an important consideration in these individuals, in addition to their visual function difficulties. Looking at the patient perspective, there was a global geographic atrophy insight survey gains that was developed. It included 203 patients with a mean age of 70 years. They had either unilateral on 58% of patients or bilateral on 42% of cases. The perceptions on speed of geographic atrophy progression and impact on independence and emotional toll is shown in this graphic. So the patients strongly agree that the impact of vision is happening or has happened faster than they expected. 69% said they're no longer able to be as independent as they'd like due to loss of vision. 68% found it hard to enjoy life fully the way they once did. And the same amount of patients had an experience that the impact of the vision decline on quality of life and independence was worse than expected. Many, also 68%, felt dependent on others due to the vision loss. And this has important considerations for the patients presenting for clinical care. 50% find it difficult to admit that that they had vision loss to friends and family. 43% feel frustration that the family did not fully appreciate challenges related to vision loss, and 35% have withdrawn from social life due to advanced dry AMD. Further on, the GAIN survey highlighted the need for education and clinician interactions in this condition. 91%, so the great majority of patients, strongly agree that they trusted their eye care professionals to make treatment decisions on their behalf. 86% stated they wish there were more educational materials available to them, to both them and family and caregivers. 84% would be willing to try a new treatment to slow the progression and preserve vision. 83% wished at the time of the diagnosis that they had more information about their condition in order to feel prepared for the impact of disease progression. 80% wished for more support from the eye care professionals. 76% stated that prior to their diagnosis, they attributed the loss of vision to a natural part of aging, and they were surprised to find that this was not indeed natural. It was part of the disease. In this module, I'll review updates in diagnosing and monitoring geographic atrophy. The differential diagnosis of geographic atrophy is important to consider. It includes chronic central serous chororetinopathy, congenital infections such as Zika virus, basal laminar deposits with pseudovitelliform detachments, pattern dystrophies, maternally inherited diabetes and deafness, central areolar choroidal dystrophy, Stargardt disease, fundus flavimacularis, Best macular dystrophy, post-macular surgery-related atrophy, and anti-VEGF therapy-related atrophy. It is very important to recognize and diagnose geographic atrophy starting with a clinical exam. First, the visual acuity is measured using reading charts. Best corrected visual acuity is typically measured using Stellan charts. Reading speed and low luminance visual acuity is sometimes performed as well. Impairments in central vision field and line detection on the AMSA grid can also be performed. Indirect ophthalmoscopy is next. On imaging, we can use a number of tools available to the armamentarium in the ophthalmology clinic, starting with color fundus photography. This has been the historic standard of care for diagnosis of geographic atrophy, but this is changing over time. Optical coherence tomography is the current standard of care and increasingly supplanting the use of color fundus photography. Fundus autofluorescence is important in prognosticating progression of geographic atrophy, and it's extremely useful when the diagnosis is unclear. Going into a little more depth on diagnostic imaging for geographic atrophy, this is how we would use color fundus photography, again, the standard historic gold standard. This correlates closely with ophthalmoscopy. It can detect drusen, atrophy, fibrosis, and focal pigmentary changes based on appearance. The drawbacks, however, are limited precision in demarcating lesion margins of geographic atrophy. They often can be hazy or they could be masked by light fundus. Unable to visualize many lesion characteristics associated with progressive disease. So we need better imaging to further characterize GA. Fundus autofluorescence is fulfilling this need by providing high contrast retinal images. This modality is able to more precisely quantify atrophy compared to color fundus photography. It can track lesion growth across visits, and this can be measured objectively. The drawbacks, however, are association with some discomfort for patients, and the fact that the atrophic borders near the foveal area may be difficult to visualize due to the normal foveal gradient in the center on fundus autofluorescence. Optical coherence tomography is present in many eye clinics these days. It is very useful because it provides in vivo cross-sectional and en-face visualization of the retina and RPE. Spectral domain OCT is widely available and comfortable for patients, and swept source OCTs have better tissue penetration. They're not yet available in all our clinics, but extremely valuable. The drawbacks of this technology is that we need to balance the level of detail needed against time constraints. High resolution imaging is more time consuming. There needs to be further development of expert consensus on demarcating lesion boundaries. This has not been reached yet, and a lot of work is in process. Another tool available is OCT imaging with angiography, OCTA. This provides enhanced 3D visualization of oculovascular network. It is non-invasive compared to dye-based imaging such as fluorescent angiography or indocyanine green angiography. It is time efficient. Considerations, however, are projection artifacts in imaging, and these are complex and require familiarity with the technology in order to provide accurate clinical assessment. This is a nice slide that showcases the multimodal approach for imaging of geographic atrophy, starting with color fundus photography, then going to autofluorescence, and you can see the hyperautofluorescence characteristics around the lesion borders. We can perform a fluorescein angiogram and look at the early and late frames to see a window defect associated with geographic atrophy. An OCT en face can also really showcase the borders of the lesions on infrared. And then we have cross-sectional images given by the OCT-B scans across the entire macula. The near-infrared image that comes with OCT is valuable and can be used as a surrogate in some clinics instead of autofluorescence. OCTA on the right shows the margins of the lesion and also rules out neovascular complexes in the wet form of advanced AMD. Biomarkers are becoming increasingly important for evaluation of clinical patients with geographic atrophy. There's a need to search for early signs of this disease as we are developing treatments. So in the early stages of dry AMD before GA, we see a presence of medium drusen, which are 63 to 124 microns in diameter. In the intermediate stage of the disease, we have a whole umbrella of biomarkers that are valuable. There are reticulosural hyperreflective foci in more advanced intermediate AMD. There's Aurora, nascent GA onset, changes in photoreceptor thickness, ellipsosome reflectivity, which is a layer of mitochondria of photoreceptors on OCT, hypertransmission defects that starts to define GA above a certain length, chordal thickness changes. Visually, on the visual function biomarker front, we see changes in best corrected visual acuity over time. Low luminance visual acuity occurs earlier because reflects patients' function in low luminance conditions, and the changes are noted earlier in the disease process. There are changes in microperimetry sensitivity, in contrast sensitivity, and dark adaptation, which is a rod function. Changes in dark adaptation happen first in this disease. Patient-reported outcomes can also be a useful way to gauge the patient experience and quantify. Other potential risk markers of disease progression are genetic profiling and changes in blood and plasma biomarkers. In the late disease, I went over the multimodal approach to GA, and we also have a variety of imaging modalities to diagnose neovascular AMD. In geographic atrophy, we now have emerging strategies for diagnosis and monitoring the disease. Visual function can be monitored using microperimetry as an example. This is an alternative to reading charts. It measures and locates areas of retinal sensitivity or retinal sensitivity loss in the back of the eye. It uses varying intensity of light to stimulate the macula in order to determine functionality of specific areas. This is similar to a peripheral visual field test, except it focuses on the macular area. The limitations are that it is time intensive, it's dependent on patient to report and recognize stimuli. Artificial intelligence is another exciting emergent strategies. AI algorithms can be used to screen patient data from multiple sources to identify high-risk individuals. Machine learning strategies use algorithms to analyze and learn from the data, such as imaging. And AI can improve accuracy and efficiency in AMD diagnostics to rule out other confounding diagnoses. These benefits can ensure timely treatment, which can reduce disease progression. Let us review exciting updates in managing geographic atrophy. In this module, I'll review the latest data on the 2 approved complement inhibitors and their role in treating geographic atrophy. Complement overactivation has been shown to be very important in geographic atrophy. Genetic polymorphisms in complement proteins have been identified in patients with AMD, and they result in increased complement activation and impaired complement regulation. Complement activation products, as you can see in the diagram on the right of the slide, are found in drusen and drusen-adjacent RPE and choroid capillaris. The complement polymorphisms are associated with a risk increase of 2.5 to 5.5 fold in developing AMD. The diagram shows you the progression of disease and how it impacts complement. So in a patient that's been exposed to light and has age as a risk factor, there is oxidative stress, and that leads to activation of the macrophages in the retinal cell. The oxidative stress leads to autoantibodies to modified surface and activation of the classical and lectin pathway. Directly, light exposure causes activation of the alternative pathway, which has been shown to be centrally implicated in geographic atrophy progression. Genetic variants of complement components result in overactivation of C3, which is part of the complement pathway. From C3 gets broken down into C3a and C3b. C3a leads to chronic inflammation in the macula, and C3b, in accumulation of this component, induces phagocytosis and destruction of cells in geographic atrophy. Accumulation of C3b induces phagocytosis and destruction of cells in the retina in geographic atrophy that further leads to death of RPE and photoreceptors as well as endothelial cells. Activation of the C5 follows, and that leads to chronic inflammation of the macula and activation of the MAC attack complex. So where do we stand in the treatment with complement inhibitors for geographic atrophy? These are the 2 available intravitreal agents that have been FDA approved. The first is evacincaptad pegol, which is dosed in 2 milligrams to each affected eye via intravitreal route every 28 days, plus minus 7. The mechanism of action is this is an RNA aptamer that binds to and inhibits complement protein C5, preventive cleavage to C5a and C5b. This decreases the membrane attack complex formation. The second agent is pegcetacoplan, dosed 15 milligrams intravitreal to the affected eye every 25 to 60 days. The mechanism of action is slightly different. This binds complement protein C3 and its activation fragment C3b, regulating cleavage of C3 and generation of downstream complement activation in the alternative pathway. Going back to the original diagram, we can see the points at which the two drugs inhibit the complement pathway. Let's briefly go over the trial designs responsible for the FDA approval of efacencaptad pegol. The key inclusion criteria of the participants are listed on the left. Notably, these trials involve patients with non-center point involving geographic atrophy. You can see that the patients were randomized to receive ACP, the 1 milligram, 2 milligram, or sham. The primary analysis was performed at month 12, and the descriptive analysis at month 18 in Gather 1. In Gather 2, the patients were randomized 1-to-1 between ACP 2 milligrams and sham, and then there was a crossover at month 12. Evacincaptad pegol was shown to reduce the growth in geographic atrophy lesions at 12 months, and this was statistically significant, and the level of reduction was 35.4% versus sham in Gather 1 and 17.7% overall in the Gather 2 study. The drug delayed progression of vision loss in a pooled post hoc analysis of both studies at 12 months. There was a reduction in persistent vision loss over 15 letters, and this is clinically meaningful. And there was also a progression to loss of driving ability that was avoided by the drug given at the 2 milligram dose. So less patients lost driving vision in month 12 than the sham participants. The safety was excellent for this drug, and the non-ocular adverse events as well as the ocular adverse events are listed here. The most common ocular AEs were conjunctival hemorrhage, increased intraocular pressure, blurred vision, and neovascular age-related macular degeneration. Next, on to pegcetacoplan. The FDA approval was based on the registration trials OAKS and DERBY. These were phase 3 clinical trials of patients with GA secondary to AMD that included participants with the GA lesion criteria listed on the left. These were both subfoveal and non-subfoveal participants. The patients are randomized 2-to-2 to 1-to-1 to receive pegcetacoplan either monthly or every other month, as well as sham monthly or every other month. The primary endpoint was read at 12 months, and there were pre-specified secondary endpoints read at 24 months as listed here. The studies continued with a 3-year open-label extension study named GALE. Pegcetacoplan led to a clinically significant reduction in geographic atrophy lesion growth at 24 months in both studies. These are nominal p-values, and the reduction was 22% to up to 22% in monthly administration and up to 18% with every other month between the two studies. In the GALE extension study, pegcetacoplan was shown to further reduce geographic atrophy lesion growth. In the non-subfoveal participants, which amounted to approximately 35% of the overall population, pegcetacoplan reduced GA lesion growth by 42% with monthly administration and 28% with every other month administration. In the subfoveal population, which represented 65% of total, the drug led to a 31% reduction with monthly and 25% reduction with every other month treatment. Pegcetacoplan was shown to delay progression of vision loss. This was the primary analysis of the GALE study. It's shown that the number of scotomatous points or blind blind spots that the patient would experience on microperimetry testing was significantly reduced by administration of pegcetacoplan in the GALE study. In a post-hoc analysis, time to severe visual impairment was increased by pegcetacoplan with 38% in the monthly group and 12% in the every other month group. The safety of pegcetacoplan in the first 12 months of the GALE study was consistent with Oaks and Derby findings. The ocular AEs are listed on this slide. There was incidence of intraocular inflammation, ischemic optic neuropathy as rare events, and there were no occlusive or non-occlusive retinitis or vasculitis reported in GALE, similar to Oaks and Derby. The REST committee report generated data on retinal vasculitis after intravitreal pegcetacoplan in a post-marketing analysis. This was a retrospective analysis of post-marketing cases of retinal vasculitis that occurred potentially associated with pegcetacoplan. These were 14 eyes of 13 patients diagnosed with retinal vasculitis. 79% of the eyes were shown to have occlusive retinal vasculopathy, and 21% had retinal vasculitis without evidence of apparent vascular occlusion. There was lack of consensus that was identified amongst the grader regarding best terminology to use for this condition. However, it is important to note that the vasculitis events occurred after the first injection in all eyes. The etiology of these events is currently unclear. However, intraocular inflammation was found to be an associative factor. Intraocular inflammation is a known risk with any intravitreal injections. The recommendations drafted by the REST committee report are the following. The physician should carefully evaluate anterior and posterior segment with dilation to detect signs of active inflammation before starting therapy. Patients need education on signs and symptoms of retinal vasculitis, and physicians advise prompt return if these develop. Retinal specialists wait at least 1 month after initial treatment in the first eye before considering treatment in fellow eyes. The guideline is to wait at least 1 month after initial treatment in the first eye before initiating treatment in the fellow eye. If intraocular inflammation develops with or without signs of retinal vasculitis, imaging is advised, including OCT, fundus photography, or ultra-widefield fluorescein angiography. This should be employed in order to evaluate for the presence of vasculopathy. The strategies for identifying candidates for complement inhibitors are listed here. The disease factors under consideration are whether the patient is symptomatic, the extent of vision loss, the documentation, whether they have fast rate of progression, and a high photoreceptor to RP ratio if this metric is available. The patient factors are ability to commit to long-term therapy, their experience with injections associated with increased willingness to start. Precautions that should be given to the patients are risk of endophthalmitis, retinal detachment, neovascular AMD, autoimmune disorders, and increased intraocular pressure associated with these injections. Contraindications for therapy are ocular or periocular infections, active intraocular inflammation, and hypersensitivity reactions. Choosing between the available therapies is via shared decision-making between the physician, patient, and caregivers. In addition to the 2 approved complement inhibitors, there's a robust pipeline of investigational therapies for managing geographic atrophy. Let's take a look at the latest research. This diagram showcases the pathways and therapeutic targets for emerging GA agents in development. The first one are visual cycletoxic byproducts that can be inhibited by visual cycle modulators. Inflammation and complement activation will be addressed with additional complement inhibitors in the pipeline. Lipoprotein accumulation by LDL-lowering drugs. Beta amyloid accumulation in the retina by anti-amyloid agents. Oxidative stress can also be targeted, chorocapillaris atrophy, and RP and photoreceptor loss. RP and photoreceptor loss are the hallmark of geographic atrophy, and they can be targeted via cell-based therapies and prosthesis. Additional investigational complement inhibitors in the pipeline are numerous, but an example is given here. A combination of pozelimab and cemdisiran um, can be used via subcutaneous injection. The mechanism of action is small interfering RNA that are designed to inhibit C5. And current evidence is based on phase 1 studies that showed a 90% reduction in C5 levels in participants. The ongoing trial is the phase 3 Sienna trial of pozelimab with cemdisiran versus placebo. Neuroprotective therapies are very promising, and these are a couple examples. ANX007 is a high affinity monoclonal antibody antigen binding fragment that binds C1q. It is a complement inhibitor, but also a neuroprotectant because it inhibits synaptic pruning in degenerative diseases such as GA. It is administered via intravitreal injection. Current evidence is based on the phase 2 Archer study, where the drug given monthly or every other month reduced vision loss versus sham. The ongoing trial is a phase 3 Archer 2 of monthly ANX007 compared to sham. It received PRIME designation in Europe. ONL-1204 is a fragment apoptosis stimulator inhibitor given via intravitreal injection. The phase 1b trial was completed with great success. The phase 2 trial is active but not yet recruiting participants. Gene therapies offer the hope to our patients for long-term durable treatment options. This example of an intravitreal injection of a gene therapy agent increases retinal cells' ability to form CD59, which inhibits C9 insertion and MAC complex formation. The phase 1 trial was completed. The Parasol phase 2 trial is currently active, and it compares a gene therapy administration with a sham procedure. Mitochondrial-targeted therapies address the oxidative stress that occurs in this disease. Amiprotide, or NTP-131, selectively targets cardiolipin within the inner mitochondrial membrane. It's administered via subcutaneous injection. It scavenges and reduces reactive oxidative species in the retina. The current evidence is based on the Reclaim 2 phase 2 study, and although this study failed based on the primary endpoint, it gathered a lot of important information about the patient characteristics and endpoints. As a result, this drug is currently being investigated in 2 phase 3 trials, Renew and Regain, that are currently recruiting participants. Risutaginib is a small peptide integrin regulator that protects human RP cells against oxidative stress. It's administered through intravitreal injection. The phase 2A was successful, seeing some best-corrected visual acuity improvements in patients with dry AMD compared to sham. The phase 2 to 3 trial is in the planning stages. Visual cycle inhibitors are also being investigated. ALK001 is a mimicker of vitamin A by reducing vitamin A dimerization and cellular damage. It's administered orally. The current evidence was based on the SAGA phase 3 study, which showed the reduction in geographic atrophy lesions versus placebo and reduction in low luminance visual acuity of loss. The current evidence is based on the phase 3 SAGA trial that demonstrated reduction in GA lesions and reduction in low luminance visual acuity loss versus placebo. Cell-based therapies are particularly exciting for our patients because they offer the hope for improved visual acuity. Oprigen is an example of one of these programs. It uses transplantation of human embryonic stem cell-derived RP cells. These are surgically delivered in the subretinal space. The phase 2 trial is currently recruiting participants. Another program is regenerative patch technology with stem cell-based therapy of a small patch of cells placed on a thin membrane that replaces lost RPE. Its feasibility and 3-year safety were demonstrated in a phase 1 to 8 trial. The patch AMD phase 2 trial is currently ongoing. Retinal prosthesis or bionic eye is very exciting as well. The Argus 2 ocular implant was approved in the US in 2013. It elicited visual perceptions via stimulation of residual neuroretinal elements. Unfortunately, it was phased out by the developer in 2019. The Prima system is a wireless subretinal prosthesis that provides partial restoration of vision with higher resolution than Argus 2. It uses mini camera mounted glasses that process environmental scenes into projection at the back of the eye. There's a feasibility study ongoing in the United States following successful studies in Europe. This slide discusses when to consider clinical trial enrollment for a patient. Our conversation with patients centers around the fact that despite recent advancements in treating GA with the approval of the two complement inhibitors, there's currently no cure for this disease. The treatments do not reverse vision loss, and progression to vision loss after diagnosis can occur rapidly in these patients, resulting in a significant burden to them and caregivers. The research pipeline for GA is robust, with several promising therapies progressing to phase 2 or 3 trials, as you have seen. Enrolling patients in these trials offers many potential benefits to patients: access to new treatment options with novel mechanisms of action, close monitoring and comprehensive care, potential for vision improving therapies, cost effective care while enrolled in the study, and supportive resources for patients and their families. In this module, let's spotlight the patients. How can we improve their experiences and outcomes while managing geographic atrophy? It is essential to consider the overall health of our patients. As physicians, we need to spend time providing education and building a rapport with them and caregivers and validating their concerns. We discuss benefits of what to expect from ongoing therapies. These therapies slows down disease progression of geographic atrophy and have the potential to preserve vision over longer time in our patients. We need to be forthright about potential risk and burdens of care. The currently FDA-approved treatments require ongoing intravitreal injections every 1 to 2 months during the lifetime of every individual. We need to start in our clinics with a thorough consent process. We need to consider, together with the patient and their family, whether to treat the worst seeing eye first in order to monitor for intraocular inflammation. If this doesn't occur, the patient can come back for evaluation of the fellow eye and potential treatment in the fellow better seeing eye after 4 weeks. We would consider avoiding complement inhibitors that are FDA approved in the patients at higher risk and when these agents are contraindicated. Patient education is key. In our clinics, we need to discuss disease progression prognosis, including the impact of foveal involvement. We need to set realistic expectations about the treatment. Delayed vision loss as opposed to vision gain. The currently approved FDA treatments do not provide vision gain, and that needs to be well understood of patients and caregivers. We emphasize the need for regular injections and the importance of adherence to these injections in order to prevent further loss of retinal tissue that's responsible for visual function. We need to go over the risks of these injections, including endophthalmitis and higher incidence of conversion to wet AMD. We need to have a thorough discussion about the potential intraocular inflammation that can rarely occur with these agents. The information about side effects and how to monitor them is critical in our clinics for these patients. We should develop a self-efficacy plan for patients to be empowered and actively involved in their care. We should schedule follow-up visits with the primary care and educate our patients on strategies to reduce the risk of progression of geographic atrophy. Examples of this include diet, with an emphasis on the Mediterranean diet, exercise, smoking cessation, meeting therapeutic targets for their comorbidities. These are aged individuals, so it is very common to have comorbid health conditions that need to be carefully addressed in our clinics. A few words on the benefits of oral supplemental micronutrients for treatment of geographic atrophy. The age-related eye disease study provided important knowledge about these micronutrients. In a post-hoc analysis of participants to GA from both the REDS and AREDS 2 trials, we have investigated the use of the REDS vitamins in these patients. Oral antioxidants that included vitamin C, E, beta-carotene, and zinc were given to 218 participants that had 392 eyes with GA. In the AREDS 2 study, the vitamin was modified to include 10 milligrams of lutein and 2 milligrams of zeaxanthin. In the AREDS 2 study, the formulation was modified, as you see here, to include lutein and zeaxanthin that protect the foveal pigment. This study enrolled a much higher number of participants, 891, with 1210 eyes of geographic atrophy. These studies have shown conclusively that the proximity-based progression towards the central macula that usually happens in geographic atrophy was slowed down in patients on micronutrients versus placebo. So it is beneficial to use these micronutrients, these vitamins in our patients to avoid their geographic atrophy from encroaching on their foveal center. The foveal center is responsible for visual acuity and sharp visual function, responsible for activities of daily living. We have newer data on the Mediterranean diet and how it impacts progression to geographic atrophy, also from the REDS and the REDS 2 studies. Based on a retrospective analysis of these studies, in 13,000 eyes that were followed over a median of 10.2 years, we have seen a significantly reduced risk of progression to GA in patients on Mediterranean diet. Specifically, there was a 29% reduction in risk of progression to GA in patients with high versus low adherence to a Mediterranean diet. And there were certain components of the Mediterranean diet that were shown to be most important. The most prominent one was a high ratio between the good fats and the bad fats, and that seemed to prevent the risk of progression to GA the most. Secondarily, it was the use of whole fruit that was important, possibly through an antioxidant effect. You can see here the tertiles of risk of progression to GA based on hazard ratios in patients that had high adherence to Mediterranean diet versus low adherence. There's a significant role of an interdisciplinary team in the care of our patients with geographic atrophy. The care, although it starts with eye care professionals such as ophthalmologists, retinal specialists, and optometrists, should be extended to primary care doctors. They can provide a lot of guidance on diet, exercise, and optimizing their health status. Also, it is important to address all the other comorbidities that would prevent our patients from coming for follow-ups and care, including intravitreal injections into our clinics. Mental health providers also play an important role in the management of GA patients because mental health disease is prominent with a risk for self-isolation and decreased social interaction in patients with GA. Support groups can be very important to geographic atrophy patients in helping them cope with their visual disability and helping them with their activities of daily living as well. Vision rehabilitation techniques from low vision optometrists and physical occupational therapists are exceedingly important and can help integrate the care between eye care professionals, especially retinal specialists, all the way to primary care and mental health providers. There should be integration between this interdisciplinary team that would ensure that our patients with GA are well taken care of and have the best possible outcomes. A referral to vision rehabilitation or low vision clinics is also very important to these participants. They can see low vision optometrists and physical occupational therapists that can help them with devices and strategies that would improve their activities of daily living and optimize their vision outcomes. These are ways in these clinics in which we can accommodate patients with vision loss. They can make use of handheld and video magnifiers, large print phones and keypads. They can use electronic reading aids such as text-to-speech devices and smart devices with accessibility features. Technology is very helpful. Lighting aids has helped a lot of my patients. Voice activating devices via smart home products, phone settings, navigation system, and canes are also very helpful. There are devices that scan to provide text-to-speech and optical character recognition, and talking devices such as watches, clocks, and kitchen tools that our patients find very helpful. It is so important to foster collaborative team model for the care of geographic atrophy patients. This way, resources can be optimized in regards to staffing for injection appointments, managing therapy inventory, and obtaining and maintaining necessary equipment, such as OCTs and autofluorescence devices for our clinics. We should ensure that the team is able to handle streamlined processes, providing updated patients' education and managing follow up scheduling. We need to consider resources for data management if it contributes to scholarly and research endeavors that can help our GA patients over time. It is very helpful to assist the patients with clinical trial identification and help them with enrollment and explain the clinical trials truly to the patients and their caregivers. Importantly, we need to address barriers to care and treatment adherence in geographic atrophy patients. Financial insurance considerations are important. We need to note whether there are geographic restrictions or inadequate access to specialists in the area, whether the patient has limited awareness and education about their condition. We also need to address psychosocial factors that are prevalent in GA, such as depression, anxiety, denial, and fear of their condition. It is important to see whether the patient has adequate or inadequate social and family support. There are health system burdens that also need to be addressed, as well as cultural and language barriers in this condition. After assessing all these barriers to care for each patient, the next steps are to connect them with the necessary support and resources in order to overcome their unique barriers to optimize their care.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by educational grants from Apellis Pharmaceuticals Incorporated and Astellas. To access all materials for this activity, visit peerview.com/GEH860.